All right, so if we're going to be performing muscle energy on the tibia, we want to start, of course, with the diagnosis. So in order to evaluate diagnosis of the tibia and restriction and freedom of range of motion of the tibia, we can do it a couple ways. One is seated, one is supine, and we're going to start in a seated position. So our main contacts are going to be the tibial tuberosity and popliteal fossa, basically holding the entire tibia in our hands. And then we're going to be taking the ankle and dorsiflexing it to stabilize the ankle and introducing a little bit of compression up to the knee. From there, we want to externally rotate the lower leg and then internally rotate the lower leg and evaluate for freedom of motion and restriction of motion. In this case, we find more restriction of motion on external rotation and more freedom of motion on internal rotation, which would suggest a somatic dysfunction diagnosis of an internally rotated tibia. In a supine position, we can also evaluate the tibia by making contact with one hand on the distal femur and one hand on the proximal tibia and adding a little bit of posterior compression and then externally rotating the tibia and internally rotating the tibia. We would, of course, do that on the other side. Externally rotate the tibia and internally rotate the tibia and compare motions. On this right-hand side, we find a greater restriction of motion on external rotation and a greater freedom of motion on internal rotation, which confirms our somatic dysfunction diagnosis of an internally rotated tibia. All right, so we're going to go over muscle energy of the tibia. And on exam, we found that the tibia has a freedom of motion in internal rotation and a restriction of motion in external rotation. So naturally, as with any post-isometric relaxation type muscle energy, we're going to want to position the segment, or in this instance, the tibia, into its barrier and then ask our patient to move into their freedoms. So in order to enhance external rotation, which is its barrier, we're going to dorsiflex the foot to stabilize the ankle. We're going to be making contact to the tibia and posteriorly to the tibia and popliteal fossa. And what we're going to be doing is moving the tibia into external rotation. Then we're going to ask our patient to twist their foot and point their toe inwards to induce internal rotation, which is their freedom of motion. We're going to isometrically resist. Then we're going to have our patient relax. When they relax, we relax. And then we follow that tibia as it moves further into external rotation through the barrier. And we find that new barrier, and we go ahead and ask our patient to contract again. Go ahead and point your toe in. And then relax. And we follow to the next barrier and twist your foot in again. Good. And then relax. And we do that a total of 3 to 5 times, bring it back to neutral, and then reassess for motion. All right, so to perform muscle energy in a prone position for the tibia, what we're going to want to do is we're going to want to flex the knee. And again, we're treating a right-sided, internally rotated tibia. We would stabilize the ankle and foot distally, and then we're also going to stabilize the fibula and tibia proximally and add a little bit of compression. In this position, we can then, again, induce internal or external rotation. In the case of an internally rotated tibia, our barrier of motion is an external rotation. So we would externally rotate the tibia until we find our barrier. And then we're going to have our patient twist their foot such that it points inward. So go ahead and point your toes inward. Good. And we're going to isometrically resist. And then relax. And when they relax, we relax. And we follow it as it moves through its barrier into further external rotation. Once we find our new barrier, we're going to ask our patient again to point their toes inwards. We resist. And we ask them to relax. And we relax. and then we follow it to its new barrier. We repeat that for a total of 3 to 5 times, then return the limb back to its neutral position. We'd bring them, of course, back into supine and retest motion.